in the second half of Chapter 12, we're going to talk about some specific pain syndromes and central sensitivity syndromes. So the only ones that I really need you to know about are what are here in the learning objectives. So this is the same 5 learning objectives from the previous lecture. And so we're going to talk about complex regional pain syndrome, chronic low back pain syndrome, 2 different types of headaches and chronic whiplash disorder, and fibromyalgia. So we're not going into extreme detail, but we're just going to touch on these a little bit. So when the pain matrix malfunctions, top-down regulation of pain is disturbed. Anti-nociception is reduced and or pro-nociception is intensified, and the result is increased pain. So in fibromyalgia, ETTH, migraine, and chronic whiplash associated disorder, those all involve disturbances of top-down regulation of pain. So it's not just something happening in the periphery, it's actually the pain matrix malfunctioning. We have central sensitization. So fibromyalgia normally results in tenderness of muscles and adjacent soft tissues, stiffness of muscles, and aching pain. It's neither a subjective pain condition nor is it a psychological disorder. At one point, it was thought to be a psychological disorder, but it's not. It's a pain matrix dysfunction. People with fibromyalgia demonstrate biological amplification of pain signals. The tendency to develop fibromyalgia is genetic, and several treatments are effective. So when we break down the word fibromyalgia, we've got algia, which is that pain, myo, which is muscle, and fibro, which is fibrous tissue. So it's pain and tenderness of muscles and adjacent soft tissues. So the painful area in fibromyalgia shows a regional rather than a dermatomal or peripheral nerve distribution. The fundamental problem with fibromyalgia is abnormal processing of pain information, resulting in the perception of pain without any painful stimulus external to the nervous system. So the alarm system is turned way up. They have an extra sensitive nervous system. So people with fibromyalgia do have structural differences in their nervous system and abnormal pain processing. So the brain in fibromyalgia has significantly less gray matter density in certain areas of the brain that inhibit pain and in stress response areas. So people with fibromyalgia have real structural and functional brain differences. A large majority of people with fibromyalgia have less pain inhibition, or significantly less active pain inhibition. So people with fibromyalgia have impaired descending pain inhibition. Regions of the brain where people without fibromyalgia have significantly more activation show up on functional MRIs. So kind of interesting. If you search the internet for fibromyalgia, you will find a million things out there, a million bits of information. But just if you think of it as an extra sensitive nervous system, that is a good way to start. In the clinic where I work, we have a chronic pain education program. It consists of 8 visits, and we talk about different ways to manage pain. One of them is exercise, stress management, pacing, using modalities such as heat or ice. So we're trying to give people the tools to manage their pain. It's not going to go away. They just have to learn how to manage it. Episodic tension type headache. The criteria for ETTH are different from the criteria for migraines. So the description is a little bit different. It usually includes mild to moderate pain, which is usually bilateral. Migraine is usually unilateral and maybe has a pulsing quality. ETTH can last from 30 minutes to 7 days, and it's not aggravated by physical activity, unlike a migraine, which ordinarily is, and it's not associated with nausea or vomiting, and that is usually the case with a migraine. Photophobia, which is light sensitivity, or phonophobia, which is sound sensitivity, may be present, but usually not both, one or the other. The mechanism that causes ETTH appears to be a hypersensitivity to nitric oxide. And remember, nitric oxide acts as a neurotransmitter, and it's the only one that doesn't need an ion channel. It can diffuse passively through the cell membrane. So we have hypersensitivity to that, and that causes that ETTH. So I would like you to be able to distinguish between ETTH and migraine. So with migraine, it's considered a neurogenic disorder. It's a disorder of sensory processing that produces a pain matrix malfunction that amplifies nociceptive signals in a certain pathway, and I don't expect you to know that pathway. It's characterized, I want you to know the characterization though, it's at least two of the following: unilateral location, a pulsating quality of pain, severity that interferes with daily activities, and aggravation from routine physical activity. It can also be accompanied with nausea and vomiting. There is a cascade of events in migraine, which I don't expect you to know, but it has to do with that trigeminal nerve thalamic pathway. 18% of females and 6% of males have one or more migraines per year. So very interesting. There are medications that can effectively treat migraines. So that's a big improvement over the last 20 years, where there didn't used to be medications, but now they have preventative ones and ones that you can take as soon as you feel the migraine coming on. There's several slides on red flags for headache, and that's just there for your information. I'm not going to expect you to know that for the exam. Chronic whiplash associated disorder is whiplash is an injury to the neck resulting from rapid acceleration or deceleration, usually in a traumatic, like car accident, is a whiplash inducing thing. In chronic whiplash associated disorder, 34% of people that had whiplash eventually have a predominantly neuropathic pain component. There's no damage to the somatosensory system. It's considered a pain matrix disorder. So there is a PowerPoint, or there's a video in the module that talks specifically about chronic whiplash associated disorder, and this is sort of a new thing. A lot of times people are recovering from whiplash and they recover just fine, but 34% of people end up with that neuropathic pain component. So there are two syndromes that are discussed in Chapter 12 that involve other symptoms in addition to the pain system, other systems. So chronic regional pain syndrome involves the somatosensory, autonomic, and motor symptoms. Sometimes the old name for chronic regional pain syndrome is reflex sympathetic dystrophy, RSD. You will occasionally see that out there, but usually CRPS is the current term for it. Chronic low back pain syndrome involves muscle guarding, disuse, and abnormal movement patterns. So complex regional pain syndrome is a syndrome of pain, vascular changes, and atrophy in an area that had a previous injury. So it most frequently follows surgery, fractures, crush injuries, or sprains. The typical signs and symptoms are worse in the distal extremity. The primary complaint is severe spontaneous pain out of proportion with the original injury. So sometimes they will actually go to the point of implanting a pain pump system to allow lower drug doses and increase drug effectiveness. Therapy can be really helpful in addressing complex regional pain syndrome. I've worked with people with complex regional pain syndrome in aquatic settings. and that the sensory input from the water circulating can have a really good effect on decreasing the spontaneous pain. So the other things we'll do is work on desensitization of the area. We'll compare sensations from the non-injured side to the injured side. The autonomic and vascular changes that you see, the skin will be tight and red and shiny, or it can be tight and pale and shiny. In the later stages of complex regional pain syndrome, so early signs are red or pale skin color, excessive sweating, edema, and skin atrophy, and that's that autonomic area. Later on, the skin becomes dry and cold, and the joints can become stiff and swollen. If the condition progresses to its late stage, you can have irreversible muscle atrophy, osteoporosis, and arthritic changes. So it's something that you really want to address because it can progress to a pretty debilitating syndrome. Chronic low back pain syndrome, the transition from acute low back pain to chronic low back pain has been characterized as a change in pain, the etiology of pain from tissue damage to a physiological impairment consisting of muscle guarding, abnormal movement, and disuse syndrome. Brain scans of people with chronic low back pain syndrome show amplified pain signals in patients with idiopathic chronic low back pain. Idiopathic, of course, meaning that we don't know what causes it. 84% of adults in their lifetime will have back pain, low back pain. A very large proportion of those people recover from it spontaneously, so they don't need any treatment for it. A very small percentage don't recover from it spontaneously and can end up with chronic low back pain. We see so many people, in whatever setting you work in physical therapy, you will see people with low back pain. So this is something that you need to know. The studies that have been done with people with chronic low back pain syndrome, the things that are most effective for treating it are normal movement patterns. And so exercise can help treat chronic low back pain. It can be the key element in treating it. Exercise can also be a key element in treating lots of other pain syndromes. So exercise, that's right in our wheelhouse. We need to do it. So there are medications that are used to treat neuropathic pain, fibromyalgia, chronic low back pain syndrome. All of these are so common that they're always coming up with new ones. I'm always hearing about new ones. Sometimes antidepressants are used in lower doses than they use for depression. Sometimes tricyclics or SSRIs. Sometimes tramadol is used to, it weakly inhibits the reuptake of serotonin and norepinephrine. So that is, of course, we send the patient to their doctor for that. They come to us for the exercise part. There are a lot of psychological factors in chronic pain. Expectations, cognition, and emotions affect the experience of pain. Anxiety and depression and catastrophizing predict reactions to pain and the ability to cope with pain. So sometimes the catastrophizing is a real thing. People with what we would consider to be fairly minor injuries say, oh my gosh, I'm going to keep getting worse, I'm going to end up in a wheelchair. That kind of thinking doesn't do anything to help remedy your pain. The amount of pain an individual expects influences the processing in both the medial and lateral pain systems. So if someone expects more pain, they're going to get more pain. You can absolutely affect the amount of pain you have with your expectations. Therapists have to address all 3 Ds of chronic pain: distress, disuse, and disability. Neglecting even one of these can cause treatment failure despite intervention for the other aspects of chronic pain. So you have to treat your patient. The pain is real. whether there's a physiological or a physical reason for it or not. So you have to address that. You have to address the disuse, and you have to address the disability. So improving the patient's function and addressing their distress is something that can really help improve the treatment for chronic pain. Psychological interventions may decrease activation of the pain system and also improve coping skills. So three of these are things we can do in PT, and one of them we have to send them to another type of therapist to have. Relaxation, breathing, and muscle relaxation, biofeedback, and imagery. We can do all of those in physical therapy. Cognitive behavioral therapy has to be done with a psychologist that specializes in that. But all of these things can help decrease activation of the pain system. Placebo-associated improvement is defined as any genuine psychologic or physiologic effect which is attributable to receiving a substance or undergoing a procedure that is not due to the inherent powers of that substance or procedure. In other words, you think it's going to work, so it works. Approaches include providing positive yet honest communication about the therapy. You have to tell people what therapy can and can't do. Providing encouragement and education, developing trust, compassion, and empathy, understanding that person as an individual, and creating rituals that provide meaning and expectancy for the person. When therapists use a supportive, genuinely caring, and encouraging communication style instead of a more distant, neutral communication, people with chronic low back pain showed significant decreases in pain rating and muscle pain sensitivity. So we have a couple different chronic pain pathways that are largely education-based in the clinic where I work, and we talk to people about the neuroscience of pain, how pain works in their body, how their nervous system works, and we try to be supportive and caring and encouraging and give people tools that they can use to improve their pain rather than just, it's not just about the exercise. Sometimes you have conflicts between patient and provider goals. People with chronic pain often want healthcare providers to acknowledge them as individuals and to have their pain recognized as biologically based. They want to see an MRI with a blip on it. They want someone to say, yes, I see that you have this problem right here. Healthcare providers are frequently more concerned with diagnosis and treatment than with providing biological explanations for chronic pain. So that's really frustrating for patients. But the most important factor in achieving a positive patient-therapist interaction is the therapist's ability to explain treatment recommendations in a way that's consistent with the patient's existing beliefs about his or her chronic pain. So you can tell people about studies and you can tell people that sort of thing, but if they don't believe it, they're not going to get better. So it's really important that you achieve that positive interaction and let them know that they can be empowered to improve their pain and decrease it.